Hi, everybody.
Hello.
Hello. Hello. Okay. We're moving on with the next part of health promotion, part 3. Okay. And today we're going to look at, first of all, the public health policy process. We're just going to go quickly through that process. And then we're going to look at models of health promotion. Okay. 3 different models. So okay, so public health policy process and models of health promotion. The first thing we're going to look at is the public health policy process. And this relates to question 1.1 in task 1. Okay, just so that you know, you have to explain the process. So these few slides are going to help you a little bit with that. So first of all, what is policy? Okay, a policy is a principle or a plan, really, and it guides the decisions, actions, and outcomes that are often a group or an organization will need to follow in certain environments. Okay, so they can be laws or they can be documents. They're often procedures. They can be a looser idea of guiding principles. If you're a very big organization, say like the NHS, they might have some guiding principles. Or it can be a statement of intent, or it can be a framework. Public policy is really policy that is created by the government, the governments of our countries. Okay. So when we're creating a policy, first of all, we need to start with the issue. That's the process. So generally, you might recognize it as a problem or an issue that needs resolving or sorting out. Because we usually create a policy when something arises and we say, oh, you know, we haven't got a plan what to do in that circumstance. So that's when we create a policy about it. Or it's usually not something that just happens once in a blue moon. It's usually something that tends to happen on a regular basis, enough for you to bother to have to write a written policy, really. Although it can be ad hoc if it's a big enough event, such as a disaster or major crises. Media attention. You normally, if you're having adverse media attention in an organization, you don't normally wait until after it's happened to have a policy. One of the first things you think about is if you're a public facing organization, you need some sort of media policy anyway. You try to do that before anything's going to happen. It could also be around sort of planned avenues like research results, which makes you think you need to change something or change the direction or respond to something that maybe wasn't happening 10 years ago that is happening now. So there could be changes in a situation. Generally, they're ones that maybe worry or concern the government. So they think, well, yeah, we might have to put a policy in place here. They could be where previous policies have failed or previous goals and plans have failed. And it could be as a result of economic issues. Very often government policies are a result of economic issues, especially at the moment. So at the moment, most of us know there's a bit of an economic crisis around fuel. I'm sure it's, well, maybe it's not as bad in your country, but it's sure quite an issue in my country. So some different policies are being created around that, and the government has have to come out with something different. Okay. So there's a policy making cycle, And it's always the same. It's something you can quote, and it's probably when you write up on this section in 1.1, you probably want to put this cycle in. You can either put it in as a diagram, or you can, put it in as a chart and talk through it. Okay. So it always starts at the top here with the pressure for change or with a new problem, as I said. The next step is to review the evidence and consult the experts. Okay, so let's have a think about, for example, the coronavirus. Okay, so the pressure for change was the fact there was an epidemic spreading. The governments looked at the evidence and spoke to the epidemiologists and the experts around infectious diseases. Out of that, they created some policy options, and they obviously had to sort of think about them. What should we do? Are the options carry on as normal? Do we shut down the country, or do we take some half measures, or do we bring in just hand washing and masks? So, there are a few different things. Shall we shut down certain towns and not others, or we shut it all down? And what they did was they had a look, they threw these options around and had a look at each option and see which had the most impact on health. Okay, this was a health issue because it was about an infectious disease. So what was the health impact on each of these options? How many people would it save from getting sick? How many people would it keep out of hospital? Or how many people may die if they didn't do something? So those are the sorts of things they weighed around. Different committees, obviously different types of experts helping out with the decision as well. They then, before they agreed it, they had to identify what sort of barriers there might be. What sort of problems would be in implementing this? Would the people accept it? Would the police have to be involved? Would the local authorities have to be involved? Would the local hospitals have to change the way they did things, which we do know that, they had to do a lot. They had to cancel routine appointments, routine consultant checkups, and routine small bits of surgery because they had to give over hospital wards to the coronavirus, as you know. So those were the barriers, and when you're putting the policy together, you try to find the area of, I suppose, least resistance. Which ones are going to be the easiest to do with the least problem? Okay. So the next thing they go on to do when they're doing policy making cycle is stakeholder consultation. Okay, and really this is as big as large as you've got the time to do. If it's something that you're just developing but not an emergency, you can have a lot of consultation with a lot of different groups of people. When they were dealing with the pandemic, they probably weren't able to consult as much as they would normally like to. So they had to sort of develop the policy, consult with the experts, in this case, people from NHS, specialist doctors, universities who did a lot of research in that, the police, because they needed to be involved, and NHS managers in general, really. And the other people they had to consult with were the members of parliament. Now, again, normally they would consult in a quite long, drawn out ways with a member of parliament. But in this case, sometimes it was done quite quickly. And some of the members of parliament objected that they weren't getting enough time to be involved. So you do have to remember, normally in your policy making cycle, you make sure the relevant people are being consulted before the policy becomes a set thing. But it's just sometimes the government doesn't do it for different reasons. In this case, it was about emergency, really, but there were still issues that getting raised. So, normally they would do that. Once they'd involved their stakeholders, they would then revise the policy, make any changes that they'd asked for, if they felt they were appropriate. In the end, they have the final decision. But, you try to make changes, you try to get people on board. And then you implement the policy, you put it into practice, you circulate it to whoever, and you make it known, you publicize it. If it's a nationwide policy like this was, they used news, regular news briefings several times during the day on the national news. They use newspapers, social media, all those sorts of ways of implementing it. If it's just what is sometimes just a boring old NHS policy that a lot of people aren't that bothered about, it wouldn't be quite so widespread. It would be on, maybe specialist websites or things that people were interested in, or on the government website. Anything that goes through the government, any changes of policy that the government makes is always on their website somewhere. Okay, but their website's huge, so sometimes you have to know where to look. That can be the difficulty. So they will implement the policy for a while, and normally after a period of time they will evaluate it. And again, coming out of that evaluation, they'll be looking at, is it working? Can it be improved? Can we change it? Can we make it easier? What sort of feedback are we getting from it? Are people happy with the policy and do they want it to keep going? Or do they want to get rid of it, and why do they want to get rid of it? How is this affecting people's day-to-day lives? Is it causing issues? And also, we say with something like the pandemic, we know it was an ongoing, evolving situation. When they thought they had something managed, then a new variant came along and gave them something else to think about. So as you can imagine, and I'm sure it was the same where you are in Malaysia, policy was changing. It was quite fluid over the period of time. So again, with sort of lockdown areas and that, they came and went a couple of times because statistics went high. So the policy was saying that if statistics went to a certain level, they might have to lock down again, which in fact they did. So normally the evaluation would be, yes, it's working, or no, it's not. Should we give it a little tweak? And then you don't normally change it until another problem comes up that stops that policy working. So that policy would have a regular review date normally. So if it's a normal day-to-day policy, it would be reviewed, once a year until it was needed changing dramatically or was, not needed anymore. But with the pandemic one, they were having to review it almost, sometimes every other day, as you can imagine. So each time they would make some changes to it, they would go through this whole cycle again. But as I said earlier, they had to do it at speed. So it didn't take the normal sort of slow, well thought out route that a normal government policy would take. Often they can take weeks and weeks, because with our government, they go to the MPs in the Commons first, and then they go to the House of Lords, then they have a little think about it, and then people make changes and hold it up. But they weren't really able to do that. It was, everyone had to agree to respond as quickly as possible and stay late for meetings and all sorts of things. So they worked very long hours, and that isn't really that usual for our members of Parliament. But this is the process anyway. And as I said, whether it's a fast process or a slow process, whether it's an emergency or whether it's a routine thing, this is the process that they will do. It will always go through these stages. Okay, so just be clear about that. And as I said, when you're looking at 1.1, what you need to do, let me remind you of what 1.1 in task 1 is literally discuss the process for developing a public health policy. So you need to really talk through this cycle. You need to talk a little bit about how it comes around, as I said before. And then maybe you can give an example. So that's policy making, really. It's quite a simple process. And that type of review cycle gets used in business and public life time and time again. You know, it's not just used for policies. It can be used for all sorts of things, really, all sorts of other plans. But as long as you're clear with that cycle, that it's got the element of sort of change, review and evaluation in it, then you'll be fine. Okay, now we're going to talk about 3 models of health promotion. Again, this question is required of you. I'm just going to tell you what task it is in. It's in, I think, task 2. No, task 3, I think. Sorry. Yeah, it's in task 3, okay? 3.1, evaluate 2 models commonly used in health promotion. Do not get this mixed up, because today I am talking to you about some of the models of health promotion, 3 models particularly. And for 3.1, you're going to have to choose 2 of them. And I don't mind which one you choose, and then you need to evaluate them. So what you need to do is look at the strengths and weaknesses of both of them, and you can compare them to each other if you want. That's fine. And then the next question will be discussing the approaches that we use to increase public awareness. The important thing is not to mix up your models and your approaches, okay? These models are a little bit complex, and they are a little bit dry, and it's sort of hard for me to sort of teach them in a way that's interesting, really. I'm telling you the truth, but you do have to do it for this assignment, okay? So I need you to get your head around them a little bit, which is why you're going to have a bit of group work, sort of trying to sort of interpret the model for me. Okay, so the first model that we're looking at is what is known as the health belief model. As you can see, it's got a little chart there, tells you about the sort of different people who are involved, the demographic variables. Demographic variables means class, gender, age, sex, maybe. Okay, so what you know, the differences in people. Psychological characteristics is when you look at people's personality, how they respond to pressure, their attitudes, all sorts of things. So starts off with that, and then it looks through some different areas. So what is the health belief model? It's a fairly old model. It was developed in the 50s in America. And it's a social psychological health behavior change model. So it tries to sort of explain and predict different types of behaviors relating to health and how people take up services. Okay. And it really suggests really that people's beliefs about health problems and their belief in what benefits them are really what encourages to either engage or not engage with healthy behavior. So it's all about what they believe is correct. So it doesn't matter what you think is correct. This model says that people will only engage if they believe something is correct. And because of that, we might need a stimulus or a cue to get people's actions. So we'll talk about that a bit more in a minute. Okay. There's 2 things to think about really here. Perceived susceptibility and perceived severity. Okay. So if I use the word perceived, what do you think I mean by that? I just referred to it earlier. It's how somebody sees something themselves. So again, it's not what you see, it's what they see. Okay. And when I'm saying see, I don't just mean with my eyes, it's sort of what they believe and what they think. Okay. So the health belief model says that people who think or perceive that they're susceptible to a particular health problem are more likely to engage in behaviors to reduce the risk of health concern. Okay, so contracting a particular illness. So if you think you may have a chance of getting that illness, you're more likely to do something about it. On the other hand, if you believe that you're not susceptible to that illness, you may sort of not really accept the fact that you might be at risk. Okay. And generally, people who believe that they are at low risk of getting illnesses tend to be more comfortable or find it easier to engage in unhealthy or risky behavior. Those who see that there might be a high risk that they can get affected by something are more likely to try and, protect themselves. Now, we can put this back into the context again of maybe the coronavirus as a recent one. Certain groups of people felt that they were not particularly at risk, mainly because of sort of some of the things people said. Now, what sort of groups of people do you think may have thought they were not particularly at risk from coronavirus? Anybody got any thoughts?
Teenagers.
Yeah, teenagers. Other, people just maybe a little bit older, people in their early 20s and that. And why do you think they think that they were not particularly at risk?
Because they thought that the immune system is still strong and healthy.
Yeah, which is sort of true to a point, isn't it? Statistically, we proved that, that young age group, although they may well have got unwell, and some of you may have had coronavirus yourself, and maybe it didn't feel so bad to you. So that you do not see yourself as a particular risk, or you've heard about other people. We know about young children going to school. In fact, they still are. And some of them are catching it and it's going around schools and all sorts of things. It's still a bit of an issue, but they might not see it as a particular risk. So when you're young as well, you think you're fairly invulnerable. If you are, generally fit and healthy, you don't expect things like that to be a risk. You don't expect to be susceptible to that illness. If, however, you have a weak chest or some concerns, like maybe if you suffer from bronchitis or asthma, and you always worry in the winter when flu comes around because you know that if you got that, it can make you quite ill, then you would be quite concerned about this disease and you would want to avoid catching it. So the health belief model, it's your belief in how susceptible you're going to be, whether you're going to catch it or not, usually affects your behavior. That sort of makes sense, I suppose, in a way. The other aspect of it was the other perception about severity as well. Okay. Now, and in this case, it would be quite subjective. It did not mean they were necessarily going through all the different statistics, looking at, getting their local hospital statistics. There may well have been some people who did that, but I can assure you there were lots who didn't. Some people were getting their statistics from social media, sometimes not with the best responses, okay? But the health belief model, again, says that if someone believes that the problem is really serious, they are again more likely to engage in the behavior. And some of them who did not think, through various reasons, various information that they'd gathered, and a lot of it was local, who just thought, oh, well, it's just going to be like having the flu or cold, you know, and I have that every year, may well have not taken their vaccines. Whereas other people would be, you know, be rushing to get their vaccines. So I guess, hopefully this makes sense. So it's that perceived, am I susceptible to it? And then add on top of it, how severe do I think it will be? And the general feeling with the health belief model is people will react on what they think rather than what someone else tells them. Okay. So if someone says, well, okay, I might get this disease, I might be physically not too bad. You know, I might be sick. I might be laid up in bed for a couple of weeks. I can hack that. You know, I've done that before. But if it means that I'm not going to get to work and I'm not going to get paid, if I don't get paid, if I don't go to work, that is serious enough for me to choose to maybe go and have the vaccine to make sure it doesn't happen. So it's not always just the severity of health. It could be about pain. It could be about whether it's life-threatening, but it could also be about how does it affect your work function and your social role. You could say, well, I've got my daughter's wedding coming up in the month. The last thing I want to do is to be struck down with coronavirus during it. So I'm going to make sure I have all my jabs. I'm going to wear my mask. I'm going to wash my hands. I'm going to be, you know, I'm going to distance a lot just to make sure I'd be fit enough for the wedding or something like that. So the health belief model uses those two areas to think about, okay? Any questions so far? So looking at the health belief model, what could be the benefits of using that model? Well, health-related behaviours are influenced by the perceived benefits. So that means if people feel it's right to maybe go and take some vaccine, there's going to be a benefit to me, it's not that hard to get them to go and do something. Okay, but it's very much down to an individual. So they will actually go and seek it out. You might not have to go looking for them with the jab, using that as an example. And they may well seek it out because of their own needs, because they've got plans and got things they want to be at. However, there can be barriers and problems. There can be obstacles to this sort of change. So even if somebody actually believes a health condition is threatening and believes that taking this action can actually reduce this threat, there may be something to stop them doing it. And it could be the sort of thing it could be, and I think we've all been here with this, you take it somewhere else, it can be the cost, it can be fear, what will be the outcomes, it can be a concern about danger, side effects of a medical procedure I've got here. Quite a lot of people wouldn't take the vaccine because that again, they'd heard weird rumors about, it might be dangerous for you, or it might have a negative effect, or it might have something in it that won't be good for you. And also lack of access. In some countries, people would have to walk miles to get to the clinic to get it. And that could cause a barrier for them actually getting it. It could be that certain countries, and there were some countries that had to wait a long time to even get their vaccines, using again the coronavirus as an example. And if you cannot get to it easily, or if you have to take 5 buses and take a day off work to go for things, these can be the barriers, even though you believe it's something that you want and you need and you should have. One of the biggest barriers is expense, costs, and as I said, it can either be those of you who are in a country where its health is insurance based, you know that yourselves, you know, having, if it's not a vaccine, if it's having a piece of surgery, well, you know you want it, but it, you know, can you afford it really? And if you can afford it, is it available? Or, you know, if you may have the money in the bank for it, but will you have to take time off work and lose money there? And that will that be just too much, you know? So lots of things to think about. These are the barriers. So if you choose to talk about this model, you need to explain why it's a benefit, because if it's people's subjective ideas, they are more willing to do something about it if they already believe it themselves. But some of the problems are cost, time, danger, fear, discomfort, pain. Some people might not take a shot. Some people don't have flu shots because it hurts, you know, they're a bit frightened of needles. So although they sort of want to, or if it was delivered another way, they'd probably go and take it, you know. Just a little summary. So another thing about the health belief model is the people who developed it suggested that they need clues to actions, cues, sorry, not clues, cues. So these are the sorts of things that you might be quite used to. You might get a text or an email from your dentist reminding you that it's time to come and get your checkup, you know. A poster that you see telling you to stop smoking, that sort of thing might work, you know, or just reminding you, drawing your attention to it. Something from your GP saying the flu clinics have started up in October and November, so time to come and get that. Things like messages for breast screening, you know, reminding you, you know, your 3 years is up, it's time to come and make your breast screening appointment, that sort of thing. Health warnings on a product might make you react to it. You pick up a packet of cigarettes and now you can't even see what make they are. It's got so many hideous health pictures and words on it that it's quite hard for people. You pick up a bottle of beer and on it there'll be something about alcohol can be dangerous for you, things like that. These are known as cues, and they tie into the health belief model to get people to actually think about what they're doing. So they make that perception. It could just be the illness of a friend. So again, with the coronavirus, I think people who had a friend or a loved one who was very ill with it would probably make them take much more precautions afterwards, you know, just for as a reaction. Okay, the next theory we're looking at is a bit fiddly, so take your time with this one. You might want to, I've put these slides up onto Google Classroom, so you might need to take some time to read this one over and over again because it's a bit harder to explain. It started out as a theory of reasoned action, and then it became the theory of planned behavior. So that's what you sort of will hear it as now. And while the previous one was developed in the 50s, so it's been around for quite a long time, this one's a little bit younger. It was developed in the 80s. And it was about, it's trying to explain all behaviors about which people have the ability to exert their own self-control. And the key part of this is about behavioral intent, and behavioral intentions, which are influenced by your attitudes, really. So it's been quite good in predicting different types of behaviors around smoking, drinking, substance use, breastfeeding. So it's about looking at trends as well. And it says that behavioral achievement depends on motivation. intention, and ability, which is actually behavioral control. And it looks at, there are 3 types of beliefs. There's the behavioral, the normative, and control. Okay, gonna be a little chart coming up a bit. And it's comprised of 6 different constructs. So think about that if you're trying to explain it. The first construct is attitudes. So whether or not the person has a favorable or an unfavorable evaluation of the behavior. Okay. So say stopping smoking. Do they feel positively about stopping smoking, or do they not care? You know, does it not matter to them? So what is their attitude towards it? The second one is behavioral intention. And this is really how motivated they are to actually, you know, say stop smoking or not. So yes, they believe smoking is not good for them. How motivated are they? And the theory of reasoned action or planned behavior says that, you know, if they're very motivated to stop smoking, they probably will. And if they're not very motivated, they probably won't. And also, this one actually brings in, the reason why this one is different to the previous one is it brings in what are known as subjective norms. Now, norms are types of behavior that happen in society. They're agreed types of behavior. So there are subjective norms and social norms. Subjective norms are, you know, my view on what is the accepted type of behavior. Social norms are what society's view on the accepted types of behavior. And sometimes it's important whether those 2 things tie together. Okay. So it's what the person brings into it is about whether people approve or disapprove of the behavior, and what their friends and people who are important to them think. And then the social norms, looking at what the wider society thinks. So again, when you're looking at smoking, the change of smoking over the last 10 years have really created these subjective and social norms about smoking. Most people now, it's like, it's, you know, it's like considered bad, unpleasant, dirty, stinky, those sort of things, which make people try harder to give up, because they're sort of fairly isolated in their view that smoking is okay. Okay. Most of the people who smoke, their children tell them off for doing so. You may do that to people that you know. So you see, this is where you've got what is known as peer group pressure. Okay. Not smoking is one thing that's a very obvious one. Drug abuse, alcohol use, those sorts of things. Theory of reasoned action, some says because of the subjective and social norms that it only works for certain types of illnesses. Obesity, you know, what's the socially accepted thing? Do people criticize you because you're overweight? Do you feel that other people think that you're not trying hard enough? You know, those might help you choose to lose weight. The other 2 things are perceived power. So the person has to think about, can I do it? So how much power do I have to actually do this or not? You want to give up smoking? You actually have the power. It's you who buys the cigarettes, you know. So in that sense, the power is with you. But do you have the behavioral control? That is the last one. So you've got attitudes, behavioral intentions, subjective norm, social norm, perceived power, and perceived behavioral control. Do I believe I am strong enough to give up smoking? Okay. And this can really vary. You might have good behavioral control for not eating cream cakes and chocolate, but you might have poor behavioral control when it comes to drinking a glass of wine. And only you know that really, but you have to reflect on your own belief of your own control. Okay. So these constructs are all part of the theory of planned behavior. There's a little, there's a little graphic just for you to see them all there, okay, and how this leads to your behavior. So there are quite a few limitations of the theory of planned behavior. So if you do use this one as an example, when you're criticizing it, these are the limitations. It assumes that the person has got all the opportunities and the resources, often the money, to be successful in performing the behavior. Which probably, if you're looking at smoking and drinking, most probably people do have, because we all know that if you don't spend your money on cigarettes and alcohol, you've got more money. So they probably have got the resources, and they've probably got the opportunity, because you have to go out of your way to buy cigarettes, especially nowadays. So it's whether they've got the opportunity and resources, regardless of whether they actually want to do it or not. On the other hand, if you needed, a piece of surgery, that might be difficult. That might be more difficult. Like say, if you need surgery because you're having pain or sort of discomfort, you may not have the opportunities and resources to have your knee surgery, even though you would like it. Okay. Another criticism, it doesn't account for other variables that factor into people's motivation. It doesn't talk about how you feel about things. It doesn't talk about whether you're frightened of doing anything. You're probably not frightened of giving up smoking, but you might be frightened of surgery, or you might have some bad past experiences of doing it. While it does consider the normative influences, so that's the pressure from society, from your small group and the big group, it doesn't take into account other environmental or economic factors that might influence people. And again, if you're using smoking, it does into that case, because it's good for the environment and it's saving you money. But this theory doesn't really take into account, so that's just sort of luck, really. It also assumes that behavior is a result of a linear decision-making process. So you just toddle along, just doing what you're doing, and you don't ever go up and down in how you feel about things. And although they put in the construct about perceived behavior control, about, what do we think our control is, it doesn't actually say anything about whether you've actually got any control. I might think that I'm very strong about, avoiding eating cakes and chocolate, but I might be wrong, and I might sort of eat them whenever they turn up. And it also doesn't really look at time frames at all. It doesn't really join up intent and when you're going to take action. So it has been used quite a lot, more than the health belief model, but it's still considered it's got its weaknesses, really. Like I said, do read them over just to pick up the detail, especially when you're getting ready for your assignment. Okay, the last one is known as the stages of change model, and that comes around, late 70s, early 80s as well. And it really came out of studies around smokers again, and to find out a little bit about why were some people able just to give up smoking, and why do some people need sort of lots of treatment and lots of help, or some people just did it. And their view with the stages of change, one of the things that they brought in that maybe the other two models didn't really look at was that some people quit smoking if and when they were ready to do so. Okay, so this model, it's its fancy title is the trans-theoretical model, but it's often known as the stages of change. So it's fine if you want to call it that. And the whole point about this model, it focuses on the decision-making process. Okay. And it's all about intentional change. It's not about accidental change or things that just happen. Okay, it's about intentional change. And it really has the belief that people don't change behaviors quickly and decisively. They don't just do it like that. I mean, some people have the idea to do it, but that they may have the idea like that, but the actual change in behavior doesn't just happen like that. The stages of change model says change in behavior, especially a behavior that's a long-standing habit, like smoking, say, occurs through a cyclical process. Okay. And it says that the person moves through 6 stages of change. And that's pre-contemplation, contemplation, preparation, action, maintenance, and termination. And termination wasn't originally part of the model, but they developed it later on. And they said, and I think this was the difference, for each stage a person's in, you have to use different intervention strategies, different strategies to help that person move on to the next stage. So you may have to do different things with them depending on where they are. So let's have a look at it. So here's my cycle. Okay, we start with pre-contemplation. It's the starting point when there is no intention of changing behavior. So someone's just merrily going about their own business, not really thinking about it at all. Or they might even know it's a problem. Okay, so obviously, you know, when we're looking at smoking or drinking, they might not see it as a problem until they read something, or I don't know, something comes to their mind, or someone else gets sick. They might get that sort of idea. So the next step is contemplation, when they suddenly, or through information or through somebody else's change, they are aware that it's a problem. It could be a problem, or, you know, not the best, but they don't necessarily have a massive commitment to do anything. So again, if you speak to a smoker, most people who've been smoking for years are aware that it's not really the healthiest thing to do, but they don't really have much commitment to action at that time. You know, they'll just brush it off and go, yes, I know, but you know, and they often make a sort of explanation. Oh, well, it keeps me comfortable, it manages my stress, or gives me something to do with my hands, or things like that. The next step is called preparation, when the person has decided they want to take action, and maybe something else has happened to make them move that step on a bit further. So at this point, the person needs to believe that that change is good, and they need to believe that maybe they can do it. So the step between contemplation and preparation is, for a lot of people, the largest step. They've decided that it's not good enough, they have to take action, but they think they can do it. Okay. The next step is actually taking the action. So the person is actively trying to change their behavior. And the next step is, once you have changed that behavior, it's about keeping yourself in that situation. And what you might have done is you might have changed that behavior, and you might have some new behaviors now that you do. Okay. But it's known as the maintenance point, where you're just going along quite nicely and you're not smoking, but you might have taken up exercise instead, or something like that. Very often people do tend to do something else to distract you, but they've got a sort of maintenance point. They don't have a cigarette in the morning, they have a coffee in the morning, whatever. Okay, they've got this maintenance point. The final one is relapse. It's acknowledging the fact that people don't always manage it the first time, which none of the others really talked about. The relapse is when you fall back to your old pattern of behavior. Something goes wrong, I don't know, you could have had an upsetting day, and all of a sudden, you might be at a party and someone offers you a cigarette and you don't think about it and you just take one. It's a relapse. You fall back to your old pattern of behavior. And then you have to go back round the circle again. Now, what might happen is if you've relapsed, you might jump, you might move very quickly through the pre-contemplation to the contemplation and then sort of start again. And this is known as the upward spiral. And the idea of the upward spiral is that each time the person goes through the cycle, they learn from each relapse, what went wrong then? Why did I relapse? What made me do it this time? And they hopefully get stronger so that relapse time is shorter or, less dramatic. So they, Prokashka and De Clement, have identified, as I said, the relapse point, which is really important. But also what they've identified is it sort of okay to relapse? And that is something that some of the other models don't really think about, that we accept the fact that people are human and people may fail a few times before they get there. And if you look at any statistics about people, say, giving up smoking, they often relapse several times before they somehow just get themselves into that maintenance point and stay there. Okay. So what are the limitations of this stages of change? We've identified that it's got a benefit because it brings the relapse time in, which nobody else really thinks about. It doesn't really think about the social context. It doesn't know about, whether you've got any money and what your situation is, what the people around you are saying. The lines between the stages, there's no really set criteria to know when someone's changed. What they did actually, when you were doing this, if you were going through this process with, say, like a smoking advisor or a psychologist who was trained to do it, they would do little questionnaires at different stages so that you can sort of identify when someone's moved from one stage to the other. But there's no sort of set time, so you have to keep sort of feeling that out with people. So you don't really know how long. So someone could be in one stage for like a year, or someone could be in one stage for a week. So it would mean quite a lot of, if your smoking advisor would have to be sort of in communication with you quite a lot to find out, where you're going if you're moving a stage. It also assumes that people make sort of very sensible and logical plans in their decision-making period, and sometimes it's not always true. So sometimes people aren't that ordered. However, it is quite useful, and you can tailor the intervention. So you can accept that someone might have a long sort of period of time in one area, and maybe give them some extra support, or find out what else you can do for them. It has a value because it encourages you to assess the different stages, and that way you can gather lots of information, not just for that person, but for everybody that you're working with. So again, if you're a specialist, if you're a specialist health advisor where you're working on people's body weight, or whether you're working on people's smoking, or whether you're working on people's alcohol consumption, these sort of things, this model can actually be quite good for those sorts of issues. How well it is for people who are, talking about life-threatening illnesses, or, making decisions about whether to have surgery or not, I'm not so sure. But I think they're quite, this one is quite good for that sort of behavioral stuff, really. Okay, I'm going to say goodbye to you, and I'll see you all